Hi, and welcome to Assessment and Screening for Co-Occurring Disorders, brought to you by allceus.com. In this course, we're going to discuss the processes of engagement and assessment, identify the purposes and process for screening versus assessment, differentiate screening from assessment, identify the 12 steps to effective assessment, and examine other issues related to the assessment of special populations. So guess what? We're going to talk a lot about screening and assessment. So let's just go ahead and get on with it. In order to do a thorough assessment, it takes time, but it also requires that we engage the client. If the client is just sitting there parroting back what they think that we want them to say, we're not going to get a clear picture of what's going on. So there are 5 key concepts that underlie effective engagement. First is universal access. There's no wrong door. So if a patient comes to you regardless of your setting, you don't say, well, we don't do that here, and shut them down. We welcome them. We understand, regardless of our setting, that patients with co-occurring disorders have multiple needs, and we try to assess them right then, because when they present, guess what? They're ready to take some sort of action for some sort of reason. So let's take advantage of that. Get them in there and not start passing them off like a hot potato. Empathic detachment means really being able to be empathetic with a client without judgment. And one of my old mentors described the difference between sympathy and empathy as sympathy is looking down a well at somebody who's stuck in it going, oh, really sucks to be you. Empathy is strapping on that rappelling gear and getting down there with them without judgment of, really, what were you thinking jumping down in the well? So empathic detachment is strapping on that rappelling gear and getting down there with the person going, no judgment how you got here. It really sucks to be you right now, and I'm going to help you get back up the well. Person-centered assessment means really focusing on the individual. Because you can take 5 different clients who have bipolar disorder and alcohol abuse as their main diagnoses, and all of them will have different presenting issues, different needs, different preferences. Cultural sensitivity, and we really need to look at culture broadly, and trauma sensitivity. The majority of our clients, unfortunately, are probably going to have some sort of trauma history. So we do need to be sensitive to that and look at how trauma is impacting not only their mood, their substance use, but also their social interactions and their sense of safety and willingness to care for themselves. So no wrong door is a formal recognition by a service system that is characterized by individuals with co-occurring disorders, or COD, being able to enter a range of community service sites. So if it's at the jail, if it's at the food stamp office, if it's at the clinician's office, the counselor's office, primary care, emergency room, all of these places are welcoming to this person to get them into the system. They serve as a conduit. People with co-occurring disorders are a high priority for engagement and treatment. Why? Well, they've got mental health and substance abuse stuff going on. So they've got a lot of risk factors for high-risk behaviors, medical complications. There's a lot of things that would make society really want to tend to this person and prevent their problem from getting any worse. And proactive efforts are necessary to welcome them into treatment and prevent them from falling through the cracks. Proactive efforts not only means when somebody comes into your office, you assess them for substance abuse, behavioral addictions, and mental health disorders, but we also educate the community, churches, business leaders, about what these things look like and about what counseling is in order to demystify the process and make sure everybody knows these are the signs that there might be a problem. And when you see there might be a problem, these are the steps you take to help someone receive services or at least be screened. We can go out to workplaces and do wellness screenings and wellness fairs. We can go to health clubs, wellness screenings, wellness fairs. Now I say health club, you automatically think healthy people working out. But when we look at it, when we look at the statistics, we realize that a lot of people who are healthy and high functioning have a lot of stuff going on. They just happen to be sort of managing it. So anywhere that you can sort of get your hands on people to do an assessment, to do a screening, or even just to educate will be huge. Public service announcements. Those are a little less welcoming because it is on TV after all. But if we can make it so they understand that there is a place, a friendly face in their community where they can go, and they understand what's going to happen. I mean, saying go to the hospital and get assessed, that's scary. If you say, you know, hi, I am the director of the intake services at such and such mental health center. If you come in for an assessment, let's take a walk and see exactly what happens. 30-second minute tour of what happens to assure people that they're not going to be met by a bunch of guys in white coats that have straight jackets that are going to take them to a room and never let them out. Because unfortunately, a lot of people still think that when they think mental health center. So we need to demystify and destigmatize that whole process and help people understand that really the majority of our population has something going on. That's unfortunate, but it's true right now. So those are the things that we need to look at so we understand that you're not unique. You're not just out there by yourself with this weird thing going on. Your neighbor, your pastor, the guy down the street may be suffering from the same thing or something similar. So no wrong door also implies opening a door so people can walk through it, welcoming. And we need to make sure that we're not meeting people and being like, oh, another assessment today. They need to feel like they're accepted, welcomed, and they have hope that something can change if they actually go through the effort to come. Empathic detachment requires the assessing clinician and everybody else in the process, the person who checks them in, the person who walks them back to the room, the assessing clinician, anybody that they encounter, acknowledge that you're working together to make decisions to support the client's best interest. You may make a recommendation, but in the interest of informed consent and least restrictive environment, we're going to let the clients know what other options are available. We'll let them know why you're making that assessment, but we'll also let them know that these are other options if you're not willing to do or don't feel comfortable doing this over here. It also means that we need to maintain an empathic connection even if the client doesn't seem to fit into your expectations, treatment categories, or preferred methods of working. I'll give you an example. I am strongly CBT. I really like to work in an action-oriented sort of system with my patients. Those patients who are really looking for more of a Rogerian style where they will clear their own blocks or a psychoanalytic style, I don't work with as well. And it's not because I have anything against them or they have anything against me. We just work in different ways. So it's not going to be effective if I try to push them into CBT. I need to find the right treatment for them. They may also come in and I see what's going on and I think, well, CBT would be perfect for that. But that's not what they're wanting. And again, I have to go with what the client wants because we know that a significant portion, up to 80% of change is a result of the interaction between the therapist and the client and has less to do with the modality. So we need to put aside our expectations when a client comes in that 12-step is the only way or CBT is the only way or whatever your preconceptions may be, or that patients with mental health issues have to have medication. Let's put those aside. Let's put those aside and really look at what's going on. So, we open that door. We welcome everybody. That's great. And unfortunately, you open that door and you don't usually have 150 people streaming in. If you do, wonderful. That's awesome. but you don't. So the people who do come in, we don't even know necessarily if they meet the criteria for treatment. What we're going to do at these health fairs, or if they come for a screening at your agency, is just that. We're screening. We're trying to decide whether this person needs an assessment and a further look, or we're checking it off going, yep, this is fine, this is fine, this is fine. It's kind of like when you go to your doctor for your annual physical. It's not because something's wrong. They're screening you to make sure you're not showing signs that warrant further investigation. We want to establish how any screening tools or questions are to be scored and establish cutoff scores. So if you're using some inventory, the ASI, the BDI, whatever, you want to figure out what level, what score indicates that the person needs to be referred out or referred up for an assessment, out, up, depending on your agency. That establishes sort of a baseline, so you're not going, well, I got this score, I have no idea what to do with it. We want to define exactly what takes place after a client scores in the positive range. They score above the cutoff, so what do you do with them? Do you refer them for an assessment? Do you refer them to detox? Do you refer them to crisis stabilization? All three of those may be options depending on how high they score, what their level of dangerousness is, or what their level of intoxication is. So you need to have protocols. Screening isn't just a fly-by-night. You show up, you do a screening, you go, oh, you may have a problem. And what to do about it. You need to have your little flow charts going. Describe a protocol for the necessary standard forms used to document the results of all later assessments. So once you do a screening, and you decide the person needs to be referred on for an assessment or for treatment, then you've got to figure out, okay, how do we maintain continuity of care? When JACO or CARF or any of the other accrediting agencies, your state agencies come in, they often use a method called the tracer method now. So they will go back to where that client entered the system, wherever that is, and then they will want to see a continuous episode of care. So we're handing off, we're communicating. We're handing off, we're communicating. Handing off, communicating. You get the idea. Not just, I made the referral and, if he followed up, he did. If he didn't, he didn't. We want to make sure that the referring clinician is at the very least following up on the referral, if not assisting in the referral and communicating with the new provider. Now, of course, with HIPAA and privacy laws and everything, you have to have releases of information unless it's a medical emergency. However, if you can, please, please, please always try to get, before an assessment, the medical records from the patient's physician, or if the patient was discharged from detox or the crisis stabilization unit or some other higher level of care or a lower level of care. Try to get that information between the screening and the assessment. So at the screening, prepare and have those releases of information ready so you can get the information you need. So when the patient comes for the assessment, you really have a pretty broad picture going on and you can make informed judgments and decisions about what needs to happen. And you need to make sure that each staff member knows each person's responsibilities. Does the clinician do the intake and the referral and everything? Or one of the places that I worked, the patient came in, they would see the office manager. The office manager would get the demographics, all the financial information, all that stuff that didn't require clinical judgment. And then they would be taken to the clinician who would do the screening or the assessment, whatever was appropriate for that patient at that point in time. So you need to make sure that everybody understands what piece of the puzzle is theirs. During the screening process, clients presenting for substance abuse treatment may be unable or unwilling to report past or present circumstances accurately. So let's look at unable first. Unable to report past circumstances accurately. They have some memory loss. They have some blanks that they just can't remember what happened. Okay, that's something to consider. We want to look at trauma. We want to look at brain damage. We want to look at anything that may have happened that may be causing that inability to remember the past. Inability to report present circumstances accurately usually refers more to either a state where they are in a psychotic episode or under the influence of alcohol or drugs. They may not be able to communicate effectively. So we need to figure out what we do during that period of time. At what point do you say, I can't screen you right now, I need to wait till your blood alcohol is at least whatever, or I need to wait until you are stabilized to the point where you have a good fund of information. Unwilling is a whole different ballgame. Unwilling implies that there may be some trauma in the past. It also implies there may be some shame. It implies that they may have an addiction that they are trying to minimize, deny, rationalize. There's a lot of reasons for it. It's important to remember that even if a client presents voluntarily or pseudo-voluntarily, that they may not give you the entire picture. They don't know you. They don't know you from Adam's house cat. So why are they going to tell you every nitty-gritty detail of their life? Even once they start to get to know you, they may be concerned that anything they tell you will either get them locked up in jail, committed to a psychiatric facility. It may get reported to their employer. When I work with law enforcement, firefighters, military, a lot of them have the concerns that if they're truly honest about what's going on, that I'm going to go running back to their place of employment and go, oh, dude, you better put this person on desk duty. 99.99999% of the time, that's not the case. There's that little sliver of a percent where somebody is a danger to themselves or others, but that's true with anybody. I'm not going to go to their employer and go, hey, Bob's got a drinking problem. But we may have to look at involuntary commitment to a detox or to a residential facility. You've got to look at what your state law requires. Now in Florida, you can Marchman Act, which is involuntary commitment to a detox facility, or Baker Act, which is a 72-hour hold at a crisis stabilization. That's not true everywhere. Explain to your clients up front, even in the screening, what the limits of confidentiality are and what you have to do if you determine that they are a threat to themselves or others. And going back to that, if they are a licensed professional or military or law enforcement, etc., and you do determine that there's a problem, it's definitely in their best interest, as well as yours, to encourage them to report themselves to their board or what have you. Not necessarily required. You need to check your state laws to see what you're required to report. But generally, if there's a serious issue, it ends up being better if they report themselves instead of the board finding out and sanctioning them. That's going to be a decision and a discussion you have, A, with your client, and B, with your attorney. Be very cognizant of how PHI and HIPAA and all that factor in before you start, telling people and making reports and doing all that kind of stuff. Clinicians who observe guardedness on the part of the client should consider the possibility of trauma. They also should consider the possibility that the client is scared about something. So don't just assume that they're being resistant. I don't really believe in resistance. I believe in self-preservation. So I ask myself, if somebody is not doing what I want them to do, why? What part of this is punishing or scary or invasive to them? Try to figure that out. It may not come right away. You may not be able to solve that puzzle. But if you notice your patient is guarded, note it, and then you can try to figure out why in the coming sessions. In screening for a history of trauma or in obtaining a preliminary diagnosis of PTSD, it can be damaging to ask the client to describe the traumatic events in detail. Don't open that box. If you're only meeting with a client for 30 minutes and you haven't met them and you haven't established their social support system and you don't have all your ducks in a row, don't go poking the bear. It doesn't make any sense. You're asking to create a situation in which your client feels unable to control their emotions and may start to decompensate. So don't poke the bear. If there is trauma, and be aware, again, a lot of people, 25% in the average population and way, way higher in your substance abuse and criminal justice population, have a history of trauma. So assume it's there. It's kind of like co-occurring disorders. It's the rule, not the exception. So we want to assume it's there. Don't ask them to describe in detail. You may ask them how it's affecting them now. If they're having flashbacks, if they're having emotional numbing, those sorts of things, to get an idea about whether PTSD may exist. But the details, whether you're curious or not, is irrelevant. They're unimportant right now. As long as you can establish that the person is safe and you can refer on to a point where they can build up their defenses and build up their support to a point where they can start exploring that stuff. When screening, it's important to limit questioning to very brief and general questions. Have you ever been a victim of a crime? Have you ever experienced trauma? And they may ask you, well, what do you mean trauma? Figure out how you're going to answer that. But again, don't ask them specific gory details. Law enforcement, they see traumatic things constantly. So you could be there for 2 or 3 days while they go through the litany of stuff that they've seen. You don't need to. And it's not helpful or healthy at this point in the screening to go there. Note that there's been trauma, and you can investigate whether it meets the criteria for ASD or PTSD in the assessment. Now we're going to move on to substance abuse. Screening for substance abuse, and I use this term to kind of generally refer to all addictions, okay? We're realizing that it's not just alcohol and drugs, it's not just prescription medications, it's gambling, it's sex, it's shopping. Anything that produces a sense of escape and or euphoria may be used in an addictive fashion. So screening begins with an inquiry about past and present addictive behaviors and problems related to those behaviors. So people who compulsively shop, they get stressed and they go out and they spend $20,000 and put it on a credit card, and their house is going into foreclosure because they've spent so much money. That kind of ramps up there with looking at a behavior that's causing a problem that they continue to do. So ask them about anything that they do that they continue to do despite the fact that it's causing them problems. Screen for the presence of substance abuse symptoms and problems. You want to do the substance abuse symptom checklist. And there are a lot of checklists out there. You can do the CAGE, you can do whatever you want to do. But let's look for symptoms. Are they using more than intended? Are they using over a longer period of time? Do they spend an inordinate amount of time planning on getting it, using it, or recovering from it? Do they have withdrawal symptoms? Do they have symptoms of tolerance? These are all things we want to figure out. Use a formal screening tool that can work around denial. One of the places I worked, we used the SASI. That doesn't happen to be my favorite, but you can use it. The Addiction Severity Index. There are several that you can find in the appendix to Treatment Improvement Protocol 42 that you can freely reproduce and use, so you don't have to worry about copyright issues. Find one, stick to it, use it consistently. And do a screening. Screen urine, saliva, or hair samples. If it's a physician's office and you can do a blood screening, all the better, because then you can have the doctor run the entire panel to rule out anything that might be causing mental health symptoms, such as hypothyroidism, hyperthyroidism, problems with blood sugar, vitamin D deficiency. You can rule out all those things. So if you can get a really good sample, that's awesome. It's ideal if you do a screening to also have the patient go to their physician and get a physical done so you can rule out any of those frontline causes for symptoms of depression, anxiety, agitation, insomnia. So, you've met with your client. You've identified there's some stuff that might need attention. So we're going to send them to an assessment. Now, some agencies will do a brief screening over the phone. And if the client meets certain criteria, they'll sign them up for an assessment. So screening, again, is not a formal process. It's to determine whether the patient needs an assessment and where to get the assessment at. If they have a high substance abuse issue and some, if you want to say background, some less severe mental health stuff going on, you may refer them to a facility that focuses more on substance abuse as opposed to a psychiatric facility, and vice versa. If their main problems are severe and persistent mental illness and, they happen to be drinking a little too much, then you're probably going to refer them to a psychiatric facility. Once you've made the referral and they're going to be assessed by the place that will probably be able to treat them, you need to engage the client. The first thing in engaging a client is not sitting there with a notepad in front of you, or worse yet, a computer, and going, okay, what's your name? What's your date of birth? That's not engaging. That makes you feel like a number. Sit down, make eye contact, chat for a few minutes. I usually apologize for the amount of paperwork we're going to have to do. But then I start, and I usually put my more superficial questions up at the front. What's going on? What brings you here today? Let's get a psychosocial history. And then we start going into the deeper stuff about trauma and abuse and things like that. Once they get to know me and I get to know them a little bit better, it makes the client feel a little bit more at ease. Try to keep your assessment short. An hour or less is ideal. Anything more than 90 minutes, and both of you are going to start losing your effectiveness. Identify and contact collaterals if you can. If you can get a release of information for family, friends, and I don't mean just some acquaintance. I mean like their best friend that they spend all day, every day with, or their partner, or somebody who is going to be a significant part of their social support system. And other providers, counselors, doctors, hospitals, etc. And remember, physical as well as psychological. Don't forget that family physician who's been seeing the patient periodically and maybe even prescribing psychotropic meds. Get that information so you have a relatively objective fund against which you can compare what the client is telling you, and you can assimilate it all. When I work with criminal justice clients, I also make sure I have their rap sheet. So I can say, well, you tell me you don't have a problem, but you've been arrested 17 times for possession. Tell me what that's about. And generally the response is, well, I wasn't convicted on any of them. Yeah, but you don't get arrested 17 times unless there's a kernel of truth to something. So you want to have something that you can use in order to have an objective frame of reference. Doesn't mean it's 100% correct, but it's more objective than what the client who is sitting before you managing your impressions is going to necessarily give you. We want to screen for and detect co-occurring disorders, mental health disorders, physical health disorders, addiction, substance abuse disorders, personality disorders, and anything else that's psychosocially going on that is impacting any of those areas. Everything folds in on itself. Kind of like when you knead bread, you have to get everything so it's all working together and mixed well. With clients, we need to remember that if they're having lots of stress in their social life, it's going to cause them anxiety, stress, anger, depression, whatever, which may end up manifesting up here in major depressive disorder, generalized anxiety disorder. There are a variety of things that you may see that are a result of situational things or inability to cope with situational things. So we want to look at the entire gamut. Now, we're not able to diagnose physical stuff, but we can identify things that might possibly be going on and contributing, and then work with a physician to rule those out. Chronic pain is a huge one. You're in pain all the time. You probably don't sleep well. You're probably not exercising as much because it hurts, which is making you grumpy. And when you're not sleeping well and you're grumpy, you tend to be shorter with people, which impairs your relationships, which can lead you to have less social support, which can lead you to be less able to cope with stress, which can ultimately lead to feelings of depression, despair, and hopelessness. Yeah. So these are the things that you want to really factor in when you're talking to a person and see how everything is intertwining. When you're doing this, you're also able, and we'll get to it in a minute, to figure out which things the person is working on or willing to work on and start pulling those strings. Because as you pull one string, it's going to affect the entire tapestry. Determine their diagnosis. And I usually go through the diagnostic checklist with the patient and go, which of these sound like they fit? And then we talk about the reason for diagnosis. I don't want a patient to become depressed. I don't want them to say, I am depressed. No, you have symptoms of depression. If they become depressed, then if they eradicate that depression, what are they? So you don't want them to become their illness. Determine their diagnosis. Help them understand its clinical shorthand so we don't have to have a 20-minute discussion with their physician. Determine their quadrant, the Minkoff model, whether they have high substance abuse and low mental health, low substance abuse and high mental health, high, or low. Tells you where they're going to go. People with low substance abuse and low mental health symptoms are going to be able to be seen in an outpatient system. Patients with high psychiatric and low mental health are probably going to be best treated in a psychiatric sort of setting. Patients with high substance abuse and low mental health are going to be able to be treated probably in one of your traditional addiction, substance abuse-oriented treatment facilities. And patients who are high in both psychiatric symptoms and substance abuse symptoms need to be referred to a facility that is specifically co-occurring enhanced. They will treat both issues at the same time, and they'll help the patient be able to figure out how to manage both of them and manage that balance. Determine their level of care. Outpatient, IOP, partial hospitalization, residential. What is it that the patient needs? The ASAM is my favorite tool to work with patient placement because it's quick. You can go through and really quickly identify the starting point for where this client probably would do best. Then you start talking to the client and you say, all right, what are we going to do here? I'm recommending partial hospitalization, which is like 20 hours a week, but you want to keep your job and you're a single parent. So you're saying that that's not going to work with your lifestyle, and residential is definitely out. So how can we make this work for you? Find a starting point and negotiate with the client from there. Determine disability and functional impairment. If there are basic functional things that are impaired, work, getting around, they can't access their medication, those sorts of things, we need to be able to help them with that. Maslow's hierarchy, that's your baseline. If the person has inability to complete activities of daily living on their own, they can't remember to take their medication, whatever the case may be, we're going to have to figure out how to help them with that. Identify strengths and supports. Identify cultural and linguistic needs and supports. Identify problem domains, and this is broad. Mental health, substance abuse, financial, educational, broad strokes right now. Determine the stage of readiness for change for each problem. They may not be ready to work on some stuff, but they may be more than ready to get rid of some other. Figure out what they're ready to work on, because a positive change here is probably going to create positive changes everywhere else. And then work with the client to plan treatment. So let's look at these in a little bit more depth. There's 12 steps in an effective assessment process. Through these steps, you're going to be able to obtain a more detailed chronological history of past mental symptoms, diagnosis, treatment and impairment, particularly those things that occurred before the onset of substance abuse and during periods of extended abstinence. Before the onset and during periods of extended abstinence, you're going to get a better idea of what is more organic mental health or environmental mental health versus side effects of intoxication or withdrawal. You're going to be able to obtain more detailed description of current strengths, supports, limitations, skill deficits, cultural barriers related to following the recommended treatment regimen for any disorder or problem. Some cultures not down with the whole 12-step big meeting, put your stuff out in public thing. Some cultures are great with it. Some cultures are not okay with taking medication. Some cultures are okay with it. To determine the stage of change for each problem and identify external contingencies that might help promote treatment adherence. So again, I said stage of change for each problem. We'll take depression, substance abuse, and marital difficulties. Well, maybe the patient is more than ready for these marital difficulties to go away because he thinks that they're making him depressed and making him drink. Okay, that's where we're going to start. So let's talk about what these marital difficulties are. External contingencies. What things happen in your environment that would help you follow through with treatment compliance if your spouse did whatever? Identify things that are going to help keep the client motivated to work on those problems. We're going to assess different dimensions. The recovery environment considers factors in the environment that may contribute to the onset or maintenance of addiction or mental illness, and factors that may support the person. So we want to look at stressors. Are they surrounded by a bunch of people who drink in an unsafe environment that is domestically violent, and what else can I throw in there? They're financially destitute. Those are a lot of things that are going to add stress and counter their ability to really work the recovery program. So we need to figure out how to deal with that. Things that may support the person in the recovery environment are strong, sober social supports, a safe home environment, a relatively healthy or amenable workplace. Look for the things that the person says, yeah, these actually enhance my life. We want to look at medical, addictive, and psychiatric comorbidity. We want to look at medical illnesses. Now, we talked about chronic pain earlier, but there are also things like hypo and hyperthyroidism, lupus, a lot of different diseases and conditions that can exacerbate or masquerade as a mental health issue. We also want to look at the side effects of medication. If they're taking lots of opiates, we know that they may have some side effects of depression. We want to take a look at that. So look at their medications. Go on rx.com or drugs.com, or I guess it's RX list. Anyway, Google it and figure out what the known side effects are. File those in your mind, and then ask the patient what they think the side effects have been. Don't start feeding them to them, because then they'll be like, yeah, 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 yeah. If you come across a list of significant side effects, then you need to look at that and talk with them about the costs and benefits and work with their physician. They may need that medication. I've worked with patients before who really did best on certain antipsychotics that had horrible side effects for them, but it did the job with their mood and really helped keep the delusions down and stabilize any bipolar symptoms. So, okay, this one's working best for you. How do we deal with all these other side effects? Most doctors, thankfully, are not keen on medicating side effects and medicating side effects of medication for side effects, because then the person ends up with 15 pills and you can't tell the forest for the trees. However, there is a time and a place. We want to look at how the substance use disorder is impacting the person's physical health and mental health. And we want to look at how the psychiatric disorder is impacting the client's substance use and physical health. They all relate. The patient will come and generally present with a problem that is most problematic for them at that point in time, the one they're most motivated to work on, or the one that they've been told they're most motivated to work on. So you need to ask them, what is it that you want to work on? And then let's look at all these other things and see, is there anything else that you think might take precedence once you identify how all these other factors may be contributing to their identified problem? We want to assess risk of harm, the person's ability and willingness to stay clean and sober, the level of treatment necessary to protect the person's safety, and obviously their suicidal and homicidal ideation and ability to go through activities of daily living. Are they able to drive safely? Are they remembering to lock their door? Are they going to forget and leave the oven on because they've got some early onset dementia? These are all things to take into consideration when making your recommendations. Engagement considers the client's willingness to participate in treatment and awareness of the problem. They can be aware but unwilling. Generally, willingness is the one that comes second. You rarely have somebody coming in saying, I am totally willing to do whatever you need to do to make it better, but I don't really have a problem. No, that's not how it usually happens. So we need to increase their awareness of the problem as well as increasing their willingness to work on that problem. Help them see how working on that problem will help them achieve their other goals. We want to look at their functional status, the degree to which they're able to fulfill social responsibilities, interact with others, maintain their vegetative status, activities of daily living, sleeping, eating, maintain their weight, etc., bathe. How are they doing? Are they able to interact with others? If they've got Asperger's, we may have to look at what level they're interacting with others. Autism. There are a lot of different disorders that impair social interaction. Substance abuse generally impairs social interaction. So we want to look at these and figure out what's going on. What is our status and how is it being impacted by the physical, the mental, and the substance? We want to look at their treatment and recovery history and recognize that clients have tools and strengths and awareness of what has and has not worked before. If they've been through treatment, they'll tell you, well, the counselor at the last place had me do this, this, and this, and it was a waste of time. Okay, why was it a waste of time? So understand whether it was the intervention itself or the application of the intervention which fell flat. Talk to the client about what they think works for them. Ask them about periods in the past when they've been clean and sober, or they haven't been depressed, or the problem hasn't been there. What's been different? Go back to this start of this current episode. What changed that triggered this episode? You can identify mitigating and exacerbating factors by having the patient explore the timeline. Look at treatment outcomes for individuals with multiple problems. You want to look at how each one has been improved, and when that improves, what happens to everything else. The person-centered assessment emphasizes that the focus of the initial contact is on identifying clients' strengths, needs, attitudes, preferences, and goals. We're going to talk about those a little bit more later. Strengths we just talked about. What is it that you've got going for you right now? In the past, when you've been clean and sober, or when you've been happy, or when you've been less stressed, what's been going for you? What's been different? What's been useful? What's been helpful? You may have to ask a couple different ways until you find the cue word for that client to go, oh yeah, I did this, and that was helpful. What are their needs? Think Maslow. Food, water, shelter, medication, relative pain-free, adequate rest. Are they getting all those? Now, we're not talking about living in a mansion and eating filet mignon every night. We're talking about getting their basic needs met. What are their goals? If, going back to that scenario before, your client wants to focus on marital problems, that's fine. You're a substance abuse counselor. You treat addiction and related issues. That's fine too, because guess what? The marital problems are probably going to start to get better as the drinking slows down. So you need to inquire about when the relationship was good before, what was different. What did his or her drinking look like when the relationship was good before? What's changed? And how did they propose, how does he or she propose to start changing it back? What is their goal for that? Find out what the client expects from treatment. Do they expect to be cured in 3 sessions? We need to kind of put the kibosh on that because it's probably not going to happen. We can give them hope. But what they've been doing for 20 years is not going to be changed in 20 minutes. So let's identify some key anchor points. They're at a 1. They want to get to a 10. What does a 2 look like? Let's see if we can get to a 2 by next week. And maybe even a 3 the week after. The higher up you go, the higher up the mountain and the harder it's going to be. Give people an idea about how long they're going to be in treatment. If you typically do 8 to 10 sessions, let them know that. 8 to 10 sessions, we see people have really reached maximal gains, and they need to take a break because they hit a plateau. They need to formalize those skills and really get them entrenched in their day-to-day living. And then some people benefit from coming back, if that's how you do it. But explain to the client what the end game is. Identify what he or she wants to change and how he or she thinks that change will occur. Are they just going to wake up one morning? Is that change going to occur when this other person or this other thing changes? Well, we need to correct those things right there because we know that it's very unlikely that we're going to change that other person or that other system or that other situation. So we need to help the client figure out how they're going to deal with that person, system, or situation as it is. And these are things you can even do during the assessment. I mean, it goes on through treatment, but if you start helping them change their cognitive perspective and take responsibility for what they can, accept the things they can change and the things they cannot change, it'll go a lot easier. Assessing conditions. Emotional, behavioral, and cognitive conditions and complications need to be assessed, including suicide potential and homicide potential and level of lethality. If somebody says, I wish I just wouldn't wake up in the morning, that's cause for concern. but is not necessarily cause for a 72-hour hold. You want to explore that with the client. Do they have future plans? Do they have a means? Do they have a plan to do it? Do they have access to those means to do it? Have they started giving away prized possessions? Have they started finalizing their affairs and tying up loose ends? Those are all things that point to a higher level of lethality. So we'd be more concerned then. Are they willing to talk about things in the future? Are they willing to agree to call you tomorrow? That helps. But the no harm contracts aren't really, they found with research, aren't really much more valuable than the paper that they're written on. So relying on saying, well, he signed a suicide prevention contract, that means he's not going to kill himself. Yeah, right. At 2 in the morning when the pain is too extreme and he or she can't get hold of anybody, that paper doesn't mean a whole lot. So we really want to have something in place, action plans, in order to help the person get through if the person doesn't warrant a referral for a 72-hour hold. We want to look at how all these things may interfere with addiction recovery efforts, because we know that addiction is going to compound things. It can mess up neurotransmitters if we're talking about drugs. It can destroy social relationships. It can destroy financial relationships. It can cause extra stress, which compounds emotional stress, anxiety, depression, which can be somaticized and cause chronic pain, ulcers, lots of other things, reduced immunity. It all kind of folds in on itself. So let's talk about how all of these things may interfere with your addiction recovery efforts. We want to ask about social functioning. Do you have sane, stable social supports? Preferably sober too. If not, we need to look for safe places for you to be. If they do, we really need to figure out which ones are true significant others, people they can call at 11 o'clock at night or 2 o'clock in the morning if they're really in crisis, versus acquaintances they know and they wouldn't dream of really even doing much more than emailing them. And we want to look at the course of the illness. When did it start? May not even know why, but let's look at when it started. What had changed? How does it go? What makes it worse? What makes it better? How did we get to this point we're at right now? Timelines. I like doing one that's big, like on a wall or on a whiteboard, because on a piece of paper you're really struggling to write. So people can really chart things and they can visually see what makes problems exacerbate and what makes them better. And then we can go back through and circle the things that they're willing to try to reintegrate into their lives. Comprehensive assessment is based on initial screening and is designed to accurately identify those who need treatment. Further evaluate the existence and severity of substance abuse issues. Permit the evaluator to learn more about the nature, correlates, and consequences of the substance-using behavior, addictive behavior, or depression. Examine the extent to which the youth or person's family can be involved not only in comprehensive assessment, but also in interventions. This applies to youth as well as adults. We need the family involved. If the family models healthy coping skills, if the family can prompt healthy coping skills, then the family is also going to benefit by becoming, guess what, healthier. It also helps the client by having people who are speaking the same language and practicing the same skills. We also want to identify specific strengths the person can use in developing an appropriate treatment plan. Remember, I talked about that timeline. All those things they circled that have helped them before, how are we going to reintegrate those? Or something like those if we can't integrate those exact things again. For some people, structure is really important. For some people, structure is the bane of their existence. But if structure is important and they lack structure right now, how could they put structure in? Assessment goals. Gather key information. Determine the client's readiness for change. Identify the problem areas, diagnoses, disabilities, and strengths. Perform a clinical exam of the functioning and well-being of the client. Really do a thorough mental status exam. Check their fund of information, their ability to remember things, all those wonderful things that we do to make sure that there might not be something else going on as far as brain damage, anything that might impair treatment. Cover the key information required for treatment matching and treatment planning. What helps you work things out? If they say talking about it, well, that's good. Talk therapy, it's a good place to start. If they like to journal, if they like to do workbooks, if they like to, there's a variety of things. Look for therapists in your community or in your facility that have different approaches: experiential, psychodrama, cognitive behavioral, Rogerian, and know how that you can match clients up so it's a good fit, so the client gets sort of the most bang for their buck. Screening and assessment instruments. You don't want to use them willy-nilly. Important features. You want to have evidence of convergent validity. The instrument's strongly correlated with other instruments that purport to measure similar constructs, which is gobbledygook for, if you're using this instrument over here that's kind of unknown, that is supposed to measure depression, make sure that it comes up with the same results that something that we are confident in, like the Beck Depression Inventory, make sure they match up. So every time the BDI says, yep, this person has significant depression, this inventory over here says the same thing. That's convergent validity. That means we know this one effectively measures depression. If this one gets the same results, then we know that they are roughly similarly valid. Evidence of reliability. Now, validity is the idea that something is measuring what it says it's going to measure. Reliability says that it can measure what it says it's going to measure every time. So if you give it to Jane on Monday and then give it to her again on Wednesday, not a whole lot of time for her to just spontaneously get better, you're going to get roughly the same results. We want to have the ability to predict relevant criteria such as school performance, criminal behavior, suicidality. Identify the availability of normative data for representative samples. Again, gobbledygook meaning make sure that the test you're using is intended for your patient population. If you're using a test designed for adults on 10-year-olds, you're probably not going to get very accurate results. If you're using a test designed for the criminal justice population or normed on the criminal justice population and you're applying it to college students, again, you may not get very accurate results. So you want to make sure that you've got generalizability based on who's taken that test before. And we want to see if we can measure changes over time. So when they come in, if you get a score of 15, and then 3 weeks later you give it to them, and theoretically you're just doing awesome and the patient is improving, and they get a score of 8. That shows significant improvement. That's a really awesome instrument. Another instrument that we used in Florida that I really loved is called the FARS, the Functional Assessment Rating Scale. And again, you can Google it, but it has a lot of granular prompts that you can use, and it's really helpful at identifying even small changes and small improvements over time. Tests that you use should include the author's description of how the instrument is administered, scored, and interpreted. It should identify the purpose of the test, for whom the test is and is not appropriate. Most of the time they say this test is identified or appropriate for this age group and this population. And anybody who doesn't fall into that is probably not appropriate for or hasn't been normed on. Identify whether it can be self-administered or it has to be given by an examiner. If you're working in an agency, something that has to be administered by an examiner is going to be a lot more problematic than something you can give the patient and go, here, fill this out and bring it to me when you're done. Identify whether training is required for the assessor. What kind, how much, how, and where it can be obtained. Training in and of itself is not a bad thing. A lot of places have training online for their inventories and their basic things. If it's something like the Myers-Briggs that's going to require intensive training, then you may want to think twice if it's going to be something you're going to implement at your agency, because it may be cost prohibitive. And where the test can be obtained and what it costs. Cost is a factor. Whether you're in private practice or a for-profit agency or a non-profit agency, cost is a factor. But also where the test can be obtained. If you have to order it and it takes 12 to 16 weeks to get there and you run out of it before you've placed another order, then you're going to be without it for 12 to 16 weeks, which is not good for your documentation. So make sure that you have the ability to access that test, in a reasonable period of time, because we all know that occasionally we get backlogged and don't order things when we need to. Selection of screening and assessment instruments for use with adolescents should be guided by several factors: the reliability and validity of the tool, the appropriateness to an adolescent population, the type of setting in which the instrument was developed, medical, school, clinical, juvenile justice, and the intended purpose of the instrument. Is it a screening instrument, an assessment instrument? What's it supposed to measure? What is it supposed to predict? In the assessment, you want to get, in addition to using some standardized instruments, you want to get demographic and historical information. Identify established or probable diagnoses and associated impairments. There is no shame in putting a rule out on your diagnosis, because you can't get everything in one 60-minute setting. So figure out what you think is going on, what the patient reports is going on. Put whatever you need to down as a rule out or as a probable diagnosis. Identify general strengths and problem areas, and a preliminary determination of the severity of the co-occurring disorders as a guide to final level of care determination. Now remember, if it's high psychiatric, high substance abuse, once a week outpatient isn't going to do it. So high is generally a residential setting. If you have a high and a low, then there's some clinical judgment in there about whether it's going to be an IOP or a residential setting. You can Google Minkoff's quadrant model to learn more about the 4 quadrants. We're not really going to go into that today, except for what we already have. Warning signs of substance abuse. Excessively worrying about whether prescription psychoactive drugs are really working, or complaints that the drug prescribed has lost its effectiveness over time. Evidence of tolerance. Now, some of your drugs you don't need to be as worried about, like your SSRIs. Some of your drugs, like your benzodiazepines, definitely need to be worried about. Displaying detailed knowledge about specific psychoactive drugs and attaching great significance to its personal impact. One client I worked with, and not psychoactive so much, but referred to opiates as being something he needed to be his uber self. And he didn't feel like he could be 100% without having opiates in his system. So he had significant attachment to that drug, and without it, he felt incomplete. Worrying about having enough pills or whether it's time to take them, to the extent that other activities revolve around the dosage schedule. So making sure they set their schedule so they can take their pills or their meds at the appropriate time, and to the extent that it's disrupting their life. continuing to use and request refills when the physical or psychological condition for which the drug was originally prescribed has or should have improved. We see this a lot in clients with, who have a traumatic injury, car accident, combat wounds, plastic surgery, anything that's invasive where they're given opiates at a pretty strong dose because they had a pretty significant injury and they don't ever stop taking them. They complain of constant pain. So doesn't mean that it's not there, but you need to use it as a warning sign and figure out the forest for the trees. Addictive behaviors to screen for: abuse of over-the-counter medication like cold pills or prescribed medication, gambling behavior, compulsive sexual behavior, internet addiction, compulsive spending, and compulsive eating. Now again, all of these can happen. I mean, most of us use the internet. Most of us spend money. We all eat. We all have sex. Some people gamble. Most people take over-the-counter prescription medications sometimes. So just because it happens doesn't mean it's an addiction. It's an addiction when 3 or more of the following occur within a 12-month period. Using more than intended. Disregarding important social occupational activities in order to engage in use of the substance. Inordinate amounts of time spent using, procuring, recovering from the effects of the addiction. Tolerance, withdrawal. You can, again, go to your DSM, you can look up at the criteria. 3 of those symptoms have to be present within a 12-month period. Generally, the short version is, if it's causing you problems in 1 or more areas of your life and you continue to do it, we probably need to look to see if there's a problem. Characteristics of past episodes of substance abuse and abstinence are important to understand. What triggered the use? What made it worse? What helped you get better? When you were abstinent, what was different? What was good about being abstinent and what was bad? Mental health symptoms before substance use started, during periods of abstinence, during periods of use, and when you stop using. And what treatments have you tried? What's worked, what hasn't? Getting to know all of these things can illuminate the role of substance abuse in maintaining, worsening, or interfering with the treatment of any mental disorder. So it's important to really try to figure out these things and educate the patient about the effects of medications and the effects of certain drugs or activities on all of the other areas of their life. Current level of impairment is determined by assessing functional capabilities and deficits. Use the ASAM PPC or the locust in order to identify sort of what's going on with your patient and determine that baseline level of care. And that's that baseline that you start talking about and the client decides whether they're going to go there or something less intense. The locus is a longer instrument, but it's more in depth. The ASAM is seems to be pretty reliable and valid in my personal experience. Of course, it's been tested to be. And I really like it because it's fast. So you're not spending a whole lot of time going through stuff with a client and having them go, yes, 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 no, can I go to sleep now? Baseline level of impairment is determined by identifying periods of extended abstinence and mental health stability. Extended abstinence and mental health stability greater than 30 days. Some patients don't have a baseline like that. So you say, okay, let's see if we can find a baseline period of extended abstinence, and that'll give us an idea about where that mental health stability is. But it has to be greater than 30 days. We really need the brain to have started clearing from the fog from the use of the drugs. The clinician determines if the client is capable of living independently, the financial stability and need for social service referrals, the existence and quality of social support and how to engage those people, and the client's level of intelligence, their insight, their judgment, their ability to comprehend things. If you have a client with a below average level of intelligence and you put them in a group, and I'm just going to exaggerate, but you put them in a group with a bunch of clients, SAMHSA clients, they're probably not going to mesh very well, and one or the other is not going to be engaged. So you need to adjust your treatment protocols to meet the client's needs and preferences. Assessment is an ongoing process that should be continuously repeated and revisited. Life changes, especially in outpatient. We need to regularly reassess suicidality, homicidality, level of stability, and sobriety. So the locus, I said earlier that it's a lot more in depth, and it assesses 5 dimensions, but really deeply, and the ASAM assesses 6 dimensions. They're color-coded so they kind of correlate. The risk of harm in the locus corresponds to acute intoxication and withdrawal potential on the ASAM. Comorbidity on the locus corresponds to biomedical conditions and emotional, behavioral, and cognitive conditions on the ASAM. Recovery support and stress on the locus corresponds to relapse, continued use, or continued problems potential. Treatment engagement and attitude and treatment history correspond to readiness for change, and this is obviously rough correlations. And then the dimension 6 on the ASAM, recovery and living environment, is kind of out there on its own, but it also can somewhat correspond with recovery support and stress. What's my point? Basically, that both of these instruments roughly address the same things. It's whatever your agency chooses to use and what you feel most comfortable with. So let's whip through these stages of change because you've heard them before. Pre-contemplation, I ain't got a problem. You can't tell me I've got a problem. You can go away now. Contemplation is when the patient identifies, yeah, I might be using too much or gambling too much or spending too much. Might be a little bit depressed or cranky, but I got it. People are just blowing it out of proportion. So they're starting to admit there might be a problem, but they're minimizing it. In preparation, they know it's a problem. And they're thinking about, yeah, I know I need to do something about that. I have all these other things I need to get off my plate first. Okay. Action is when the patient not only knows they've got a problem, but they're willing to work on it. They're presenting themselves for an assessment, they're enrolling in treatment, and they're doing what they can to participate in treatment. And that's individualized. Not every patient is going to be gung-ho the minute they get out the chute. Some patients will be gung-ho, they'll get out the chute, and then they'll stop and freeze in their tracks like a deer in headlights. That's okay. As long as they don't run back the other way, we're really, really happy. And if they start to run, we've got to figure out how to get them re-engaged. During the maintenance period, the patient has achieved some level of stability. They're trying to maintain and integrate those new skills, strengthen the ones they had that worked already, and integrate any new ones. So after you've done all this, then you get to write a report. The report identifies the severity of the substance use and mental health disorders and any identified potential physical issues that may be going on. It identifies factors that contribute to or are related to the substance use disorder and or the mental health disorder. Strengths-based when possible. So identifying what makes the substance use disorder remit, identifying what helps get the depression to lift a little bit. Identifies a corrective plan of action to address the problem areas. Okay, you've identified depression. Your goal is to be able to get out of bed 6 out of every 7 days, not feel like you're going to cry most of the time. Whatever the patient identifies as observable, measurable goals, put those down. And then say, okay, so what's helped you do that in the past? Let's start with that. Details an interim plan to ensure that the treatment plan is implemented and monitored to its conclusion. Baby steps. You want to make sure that they have incremental objectives so they don't get frustrated. They need to have periodic rewards. Rewards engender hope and motivation. We need to make recommendations for referral to agencies or services and describe how resources and services of multiple agencies can best be coordinated and integrated. So the take home from all of this is the assessment report is not a regurgitation of the assessment. It's an integrated summary that says, okay, patient presents with depression that seems to be influenced by blah, blah, and blah, and in order to address these issues, we've identified these strengths and these needed resources. So give your best judgment, best educated guess about how all these things are interplaying, and write your report. So quickly, we're going to go through a couple special populations. The elderly. Personal areas of concern most likely to motivate older substance abusers include their physical health, loss of independence, financial security, and maintenance of independence. So you want to really use those areas to say, okay, let's look at the substance abuse and how it's impacting your physical health. And I know the last thing you want to do is be bedridden in a nursing home. As older patients undergo key life transitions or take on new and stressful roles, vulnerability to alcohol or prescription drugs may increase. I don't know about you, but a lot of people that I know who fall into the category of elderly, they have a whole bag of pills they take every day. So having all that available tends to make it a little bit easier to slip into an addictive or abusive method of using medications. Risk factor life transitions include menopause, a newly empty nest, approaching retirement, or death or illness of a child or spouse. The recommendation is that every 60-year-old and older should be screened for alcohol and prescription drug abuse as part of his or her regular physical exam. So the doctor should be doing this, doing the screening and referring out for assessment if appropriate. When we screen adolescents, you want to make sure the process takes no more than 30 minutes. Use instruments simple enough that a wide range of health professionals can administer. You never know where an adolescent's going to enter the system. And focus on the adolescent's substance use severity and a core group of associated factors such as legal problems, mental health status, educational functioning, and living situation. Hit the basics, that base level of Maslow's hierarchy for the adolescent. Focus on those. You've only got 30 minutes. You've got to pick and choose. When assessing an adolescent, it's important to remember that adolescents may define family in non-traditional ways. Could be their friends, it could be their peer group, it could be the gang that they run with. The law and society may define family in ways that differ from the actual experiences of substance abusing youth. The law is important because sometimes you have to inform parents when someone under the age of 18 comes to seek services. If they don't want their biological parents informed, you've got a bit of a quandary. Cultural and ethnic differences in family structures should be respected. It's important to be aware that substance abuse may be a symptom of a much deeper problem. Mental health, trauma, abuse, etc. Again, don't go there in the screening. And in the assessment, tread lightly to figure out what may or may not be there. until you figure out how much support this adolescent has before you start poking the bear. When a program that screens, assesses, or treats adolescents asks a school, doctor, or parent to verify information it has obtained from the adolescent, it's making client identifying disclosure that the adolescent has sought services. Duh. Which means what? With the exception of the parent who may be entitled by law, we need to be cognizant of HIPAA regulations and get releases of information signed. The federal regulations, CFR 42, generally do not allow this kind of disclosure unless the adolescent consents. Laws are governed by the federal regulations, CFR 42 and 45, the federal standards for privacy of individually identifiable health information. Be familiar. I'm not going to go into detail on all that. We have laws and ethics classes you can take. Be familiar with your state regulations for required reporting and when you can and cannot see an adolescent without parental permission. Exceptions to the federal confidentiality rules prohibiting disclosure regarding adolescents seeking or receiving substance use disorder include information that does not reveal the client as having a substance use disorder, information ordered by the court after a hearing, medical emergencies, information regarding crimes on program premises or against program personnel, or information shared with an outside agency that provides service. Now, the outside agency, you probably need a release for, and if you're revealing that the client is seeking any kind of services, you probably need a release unless it's one of those standard reasons to breach confidentiality. Critical components of the assessment. So this is our review now, so we're almost there. Assessment is about getting to know a person with complex and individual needs. Don't rely on tools alone. Talk to them. They're humans. Turn away from your computer. I know. Put down the keyboard. Do not rely on tools alone. Always make every effort to contact all involved parties. Don't allow preconceptions to interfere with learning about what the client really needs. Be familiar with diagnostic criteria. Go figure. Medical disorders that mimic mental health issues, and side effects of medications that mimic mental health issues, and common psychosocial issues which may exacerbate the presenting problems. Know the process for referring clients for mental health case management services or for collaborating with other treatment providers. Don't assume there's one correct treatment approach. There's not. Ask the client what works for them. If they say one thing and they try it and it's not working this time, be open to trying something else. It's not a personal reflection on you. It's what the client needs at that point in time. It's about the client. Be familiar with the specific role that your program or setting plays in delivering services related to co-occurring disorders. Don't be afraid to admit when you don't know. If you don't know something, say, I don't really know. Let me look that up. Or hang on a second, let's look it up on the computer. That is the one good thing about computers. You can often answer a lot of questions real quickly if you have a reliable source of information. And there are a lot of sources on the internet that are not reliable, so make sure you're using a reliable one. Remember that co-occurring disorders are the rule, not the exception. We expect if somebody has a substance use disorder, they probably have some sort of mood or personality disorder, generally mood disorder, also going on that needs to be attended to. Co-occurring disorders are the rule, not the exception. Where did I hear that? It's important to identify the interactions between addiction, mental health, social support, and quality of life. Assessment instruments will only provide you a partial picture, and each individual is unique and has their own strengths, needs, attitudes, preferences, and goals. Thank you for tuning in today, and have a wonderful rest of your day.